Hello everyone, myself Dr. J. Tharani, Assistant Professor in the Department of Diagnosis, Faculty of Radiology, under Sri Lakshmi Narayana Institute of Medical Sciences, Puducherry, which is affiliated under Bharat Institute of Higher Education and Research. And this is my topic, pancreas and spleen. Pancreas. Pancreas is an unpaired organ that has endocrine and exocrine functions with the role of glucose metabolism and digestion. It consists of four parts: head, uncinate process, neck, and body, and tail also. So, total five parts. Head. The thickest part lies to the right of the superior mesenteric vessels. Uncinate process, which is the extension of the head posterior to the superior mesenteric vein, superior mesenteric artery, and it lies within the C-shaped concavity of the duodenum, that is T2 and D3. Neck, which is the thinnest part, which is lies anterior to the SMA, SMV, and SMV joins splenic vein behind the pancreatic neck to form portal vein. Body, main part, which is lies left to the SMA and SMV. Anterior surface is covered with peritoneum, forming the posterior surface of the omental bursa. Splenic vein lies in the groove posterior to the surface body. Arterial supply. The arterial supply to the head is mainly from the inferior and superior pancreaticoduodenal arteries. Branches from the phrenic artery supply the neck, body, and tail via multiple branches, including the dorsal pancreatic artery, greater pancreatic artery, and transverse pancreatic artery. Venous drainage. From the head, the superior pancreaticoduodenal vein drains into the portal vein, and inferior pancreaticoduodenal vein drains into the superior mesenteric vein. Nerve supply. Supply greater and lesser splanchnic nerves to the celiac and superior mesenteric plexus. Parasympathetic from posterior vagal trunk. Lymphatic drainage. Follows blood vessels, collects in the splenic, celiac, and superior mesenteric and hepatic lymph nodes. This is the normal pancreatic anatomy on ultrasound. Here, we can see this is a transverse section of the liver in the subxiphoid view, showing a echogenic or similar to echotexture of the pancreas to the liver. And this is aorta, this is SMA, this is a portosplenic confluence, and on the right side, this is a normal structure of the pancreas on the ultrasound. Coming to the congenital anomalies, pancreas. It is a morphologic anomaly that results in pancreatic tissue completely or incompletely encircling the duodenum. This condition can cause duodenal obstruction. It is of two types: complete and incomplete. Complete annular pancreas, pancreatic parenchyma, or an annular duct seen completely surrounding the duodenum. This one in the second image. Incomplete annular pancreas, it annulus does not surround the duodenum, completely giving rise to the crocodile jaw appearance. This is this is a this is two images showing the annular pancreas. First image, this is the MR T1 rated image showing taken in the oral contrast, showing a pancreatic tissue completely encircling the duodenum. This is the complete annular pancreas. And on 3D MRCP image showing a filling defect noted in the duodenum. Where noted in the duodenum. This is annular pancreas. Pancreatic divisum. Pancreatic divisum, the dorsal pancreatic duct is in direct continuity with the duct of Santorini, which drains into the minor papilla. Ventral pancreatic duct does not communicate with the dorsal pancreatic duct and joins with the distal common bile duct into the major papilla. This is the image this is a cross image which shows the main pancreatic duct directly drains into the duodenum, but there is no communication with the main pancreatic duct with the duct of Santorini, which is seen draining into the major papilla. So this is showing the pancreatic division. There is an axial CCT image showing a two different ducts, which is seen draining into the two different parts of the duodenum, as confirmed by the 3D MRCP image. Ectopic pancreas. It is also known as the heterotropic pancreatic tissue. Refers to the presence of pancreatic tissue in the submucosal, muscularis, or subserosal layer of luminal gastrointestinal tract outside the normal confines of the pancreas. Location include proximal duodenum, gastric antrum, proximal jejunum, mecal diverticulum, and ileum. Ectopic tissue on the barium contrast study. So these both are a barium follow-through studies showing a filling defect at the gastric antrum. Acute pancreatitis. The diagnosis of acute pancreatitis requires two of the following three features: abdominal pain consistent with acute pancreatitis include acute onset of persistent severe epigastric pain, often radiating to the back, serum lipase or amylase activity at least three times greater than the upper limit of normal, characteristic finding of acute pancreatitis on the CCT and less commonly on MRI or ultrasound. The diagnosis is usually established when there is combination of abdominal pain and elevated enzymes, and CCT is not required unless there is uncertainty about the diagnosis. This is the flow chart. Acute pancreatitis consists of two phases, that is early and late. Early is first week, late is after first week. And severity, mild, moderate, and severe. Mild means no organ failure, moderate, organ failure less than 48 hours, severe, organ failure longer than 48 hours. Two types: edematous, necrotizing. Edematous, less than 4 week, acute pancreatic collection, more than 4 week, pseudocyst. Necrotizing, less than 4 week, acute necrotic collection, more than 4 week, walled off necrosis. Now, coming to the fluid collections in acute pancreatitis, there are two types: interstitial pancreatitis and necrotizing pancreatitis. Interstitial is less than 4 weeks, acute pancreatic collection, which in turn, if it is more than 4 weeks, then it is pseudocyst, as discussed earlier. Necrotizing pancreatitis, if it is less than 4, acute necrotizing collection, more than 4 weeks, walled off necrosis. Clinical outcomes of acute pancreatitis. Clinical outcome. See, if it is mild or known organ failure, then it's 90 to 95% it is mild. 5 to 10% will progress to severe necrotizing organ failure. And there are 60% chance that it goes to the sterile necrosis, and which in turn leads to the 95% of mortality mortality. And if 40% infected necrosis will go towards the mortality of 15 to 25%. So how do you create the pancreatitis? There are two ways. One is CT severity index, other is modified CT severity index. Coming to the CT severity index, which is the old system, which we are not following now, that is pancreatic inflammation. In pancreatic inflammation, the subpoints are normal pancreas, enlargement of pancreas, peripancreatic inflammation, one acute pancreatic fluid collection, more than or equal to acute pancreatic fluid collection, and they are given the grade 0, 1, 2, 3, 4. Pancreatic necrosis, none, less than 30%, 30% to 50%, more than 50%. That is given the score 0, 2, 4, 6, maximum 10 points. There is a slight modification to the CT severity index, modified CT severity index. In that, we there is an extra point like complications of pancreatitis, like ascites, pleural effusion, wall of necrosis, pseudocyst, and all. That is given as 0.02, and others are same. Fluid collection. The acute pancreatic fluid collections are generally seen within the first 4 weeks and pseudocysts after 4 weeks. Acute pancreatic fluid collection characteristically do not have a solid component, a lack of discrete wall, and are located near the pancreas. Develop in up to 50% of the patients with acute pancreatitis within the first few days of pancreatitis. This is a CT image with a patient in a 43-year-old patient with acute epigastric pain, showing a marked enlargement of pancreas with few areas of non-enhancement and adjacent fluid collection and ascites, and we can see the fluid is tracking along the perirenal space. Since pancreas is a retroperitoneal organ, it stays within that space, that is a perirenal space, and it starts tracking along the gerotas and anterior pararenal fascia and paracolic gutters. And we can see in the minimal pericholecystic fluid collection is also there. Pseudocyst of pancreas. When an acute pancreatic collection becomes encapsulated by the fibrous wall more than 4 weeks after the symptom of onset, it is referred to as pseudocyst. Pseudocysts often resolve spontaneously when they lose communication with the pancreatic duct. Pseudocysts develop during the initial attack of pancreatitis in 1 to 3% of the patients. This is a CECT, CECT in a portal venous phase in a patient of 43, in the same patient who came for a follow-up after 4 weeks, showing a well-defined, circumscribed cystic mass noted in the peripancreatic region. It's also similar mass which is seen near the tail region. These are the pseudocysts. Coming to the necrotizing pancreatitis. It is represent a severe form of acute pancreatitis. It is considered as subtype of acute pancreatitis as necrosis. Usually tends to occur early within the first 24 to 48 hours, but can also rarely occur with subacute forms. A key feature is significant amount of pancreatic and peripancreatic tissue necrosis associated with pancreatitis. This is a CCT abdomen in a portal venous phase. In a portal venous phase in a 43-year-old man, a 45-year-old man came with a history of the epigastric pain. We can see we can see pancreatic is not visualized separately, but it is enlarged with encapsulated non-enhancing collection with non-enhancing pancreatic tissue. So this is the necrotizing collection. Uh, coming to few cases, this is the case of acute pancreatitis with necrosis evolving into the Waldorf necrosis. Now, this is A image. You can see here, this is the 50-year-old man came with complaints of epigastric pain, showing an enlargement of pancreas with peripancreatic fluid collection and no, and areas of non-enhancement between the pancreatic tissue, suggestive of acute necrotizing pancreatitis. Its CT severity score came out to be 8 out of 10, which is very poor prognosis. And after 4 weeks, when we gave the antibiotics and the other supplements, now the tail region has been the tail region has been transformed or has been converted to the well-defined, well-subscribed cystic lesion in the tail of the pancreas. So this is the Waldorf necrosis. There are some signs of acute pancreatitis, and this is a frontal scanogram image showing that there is a divide of colonic tissue noted in the noted in the splenic flexure. This is due to the collection from the pancreatitis. Chronic pancreatitis. It represents the end result of continuous prolonged inflammatory and fibrosing process that affects the pancreas. This results in irreversible morphologic changes and permanent endocrine or exocrine pancreatic dysfunction. Pain is the predominant clinical finding in the 95% of the patient with chronic pancreatitis. The pain typically radiates from the epigastrium through the back and can be constant or intermittent. Chronic pancreatitis. This is a CCT image taken in the arterial phase showing a marked atrophy of the pancreas with few parenchymal and intraductal calcification with prominent main pancreatic duct. On the B image, which is the MR T1 weighted MR T1 fat suppressed MR weighted image showing a atrophic pancreas with few hypointense areas suggesting calcifications. Group pancreatitis. Patients who suffered repeated episodes from the pancreatitis or acute exaggeration of chronic pancreatitis may develop a form of segmental pancreatitis called as group pancreatitis, in which the inflammatory reaction and fluid collection dissect into the groove between the duodenum and head of the pancreas and common bile duct. Group pancreatitis has been most frequently reported in young men with a history of alcohol abuse. And group pancreatitis should be distinguished from the pancreatic head adenocarcinoma. And how will you differentiate these both? By for a sign called duct interruption sign. Duct is interrupted in the head of the carcinoma head of the pancreas, but the duct penetration sign is seen in group pancreatitis. Here, this is a CCD image taken at the portal venous phase, showing a well-defined non-enhancing mass noted in the groove of the pancreas between the head and the duodenum, with no evidence of adjacent inflammatory changes. Autoimmune pancreatitis. Autoimmune pancreatitis has an autoimmune mechanism and has been seen as an immunoglobulin G subtype 4 systemic disease. It can affect multiple organs, including the pancreas, bile ducts, kidney, retroperitoneum, lungs, salivary glands, and lymph nodes. It may coexist with diabetes mellitus and autoimmune diseases such as Sjogren's syndrome, primary sclerosing cholangitis, and primary biliary cirrhosis. Now, this is a CCT image taken at the arterial phase showing a marked enlarged pancreas with loss of enhancement and loss of enhancement and density, giving rise to the sausage sign. So, sausage-shaped pancreas is seen in autoimmune pancreatitis. Pancreatic cysts. Pancreatic cysts can be characterized into the following groups: pseudocyst, that is common cystic neoplasm, and uncommon. Common are IPMN, serous cystic neoplasm, mucinous cystic neoplasm. Uncommon are SPEN, tumor with cystic degeneration, adenocarcinoma of neuroendocrine tumor. And this is a graphical representation. At the tail region, most common is pseudocyst with debris. And within the duct is IPMN, that is intraductal papillary mucinous neoplasm. Body is mucinous cystic neoplasm. IPMN branch type, which is two types are there for IPMN, which is the main duct and side branch type. And on a head, there is we can see the serous cystic neoplasm with central calcific area. Peripheral calcification seen in mucinous, central is seen in serous. And head, most common is serous, and body, most common is mucinous. Now, coming in the age classification, age. SCN, that is a serous cystic, which is a grandma tumor, which is seen in the age groups of 60 to 70. It is a lobulated and 18% central scar with calcification, which we have discussed earlier. MCN, that is mucinous, which is a mother, that is 40 to 50, means 40th decade. And peripheral calcification. Main duct, malignant potential, both are equal, 60 to 80. Side branch, same, 30. And this is a pancreatic cyst, same as previous. Now, this is a T2 weighted. First, is all our MR images. First is T2 weighted MR image showing atrophy, marked atrophy of the pancreas with the lobulated hyperintense mass with central stellate scar noted in the head of the pancreas, which is seen confirmed by the 3D MRCP image, but there is no upstream dilatation of CBT. Mucinous cystic neoplasm. This is a paramalignant tumor may transform into the mucinous cystic adenocarcinoma, exclusively seen in the women, typically in mother and median age group of 40 to 50 years. Macrocystic with thick wall septations, peripheral calcification seen in 25% location in the tail and body of pancreas. Most are symptomatic, present with abdominal pain. This is a CECT abdomen in the axial phase, in the axial section, showing a well-defined a large cystic lesion with a peripheral calcification noted in the body and tail of the pancreas. And this is also demonstrating mucinous cystic neoplasm, which is in a 43-year-old woman. You can see the well-defined on T2 weighted axial image at the level of the kidneys, showing a well-defined, well-defined T2 hyperintense lesion noted in the tail. On T1 fat sat, it is being suppressed. No, no, sorry, it is not being suppressed. It's a cystic lesion on. Mucinous adenocarcinoma, which is a very rare entity. You can see the ill-defined mass in the body of pancreas with the liver mets. This is a main duct IPMN with adenocarcinoma in a 74-year-old woman. You can see the well-defined, ill-defined mass noted in the body of the pancreas, which is seen communicating with the main pancreatic duct, causing the dilatation and causing the dilatation of main pancreatic duct, dilatation and tortuosity of main pancreatic duct, and causing upstream dilatation of the CBD. And there is a branch duct which is seen in the side branches, but not involving the main branch. And this is the main branch as we discussed earlier, causing the tortuosity and dilatation of the main branch. Coming to the pancreatic adenocarcinoma. 65% of the pancreatic adenocarcinoma are located within the head, 15% in the body, and 10% in the tail. The remaining 10% being the multifocal or diffuse. Tumors of the head usually present earlier due to obstructive jaundice. Tumors of the body and tail tend to present late and they are associated with worse prognosis. 65% from the head, 15% from the body, and 10% from the tail. This is the first image is a CCT taken in the coronal reformat image showing taken in a venous phase showing a ill-defined mass noted in the head and uncinate process causing the double duct sign. And on D image, which is an endoscopic ultrasound, showing the mass. Pancreatic adenocarcinoma in an 81 history of jaundice and gastric outlet obstruction. Here we can see there is a ill-defined mass in the uncinate and head of the pancreas, causing invasion into the duodenum, causing the obstruction, and double duct sign seen in the C image. Pancreatic adenocarcinoma in a 70-year-old man with history of pancreatitis. We can see there is a ill-defined mass noted in the tail of the pancreas, causing the with the duct interruption sign And there is another mass which is seen in the head of the pancreas. So this is the main topic. This is a resectability criteria. On what basis you will treat the patients with pancreatic adenocarcinoma? There are three things you should know: resectable, borderline, and irresectable. And you should know the definition of abutment and encasement. Abutment means less than 180 degree 180 degree degree contact with the tumor. That is abutment. If tumor is more than 180-degree contact with the vessel, then it is encasement. So resectable is arterial. Arterial, no contact. Venous, less than 180 degree without contour irregularity. Borderline. Head and uncinate process. Contact with common hepatic artery without extension to without extension to the celiac artery or hepatic artery bifurcation, or abutment and no extension to the SMA or variant artery. Body and tail, abutment to the celiac axis or encasement of the celiac axis without involvement of the aorta or gastroduodenal artery. And more than 180 degree or with contour irregularity, thrombosis, resection, and reconstruction possible. Irresectable, head and uncinate process, more than 180-degree contact with the SMA or CA, body and tail, more than 180-degree contact with the SMA or CA, less than 180 degree when aortic involvement, and one more than 180 degree or with contour irregularity or thrombosis, resection, and reconstruction not possible. Morphological changes that suggest vascular invasion. Teardrop sign. It refers to the change in shape of the portal vein or superior mesenteric vein from oval or round to teardrop. This can be caused by the tumor encasement or tethering by adjacent fibrosis. The vessel contour irregularity. Irregularity of a vessel is suggestive of vascular invasion, even more so in arteries, since the wall of the artery is thicker than the vein. Thrombosis. The presence of thrombus in the artery is suggestive of vascular invasion. Morphological sign. We can see here there is a CCT image taken in the venous phase showing a contour irregularity of the superior mesenteric vein in the form of a teardrop sign. Same confirmed in the axial, which is seeing a contour irregularity of the superior mesenteric artery, and the same confirmed in the coronal image. Solid pseudopapillary neoplasms. These tumors of the pancreas are rare and usually benign pancreatic cystic neoplasms. These are seen in young females, usually seen as well-capsulated lesion with a varying solid and cystic component owing to the hemorrhagic degeneration. Following IV contrast, the administrating enhancing solid areas are typically noted peripherally, whereas cystic spaces are usually more centrally located. Calcification and enhancing solid areas may present at the periphery of the mass. This is a large, this is solid pseudopapillary neoplasm in a 25-year-old male. So this is the first image, T1 FACSAT image showing a well-defined large cystic mass with solid component noted in the head of the pancreas. However, there is no IHBRD noted. Insulinoma. These are the most common functioning pancreatic neuroectodermal tumors. It may represent Whipple-Strad, neuromuscular disorder, hypoglycemia, and symptom reversal with administration of the glucose. This 50% of the lesions are found in the head of the pancreas, remaining elsewhere, with the gland 85% are solitary and 0.5% of the pancreatic lesions are extrapancreatic. And this is a axial reformat image showing intensely enhancing mass in the body of the pancreas. And this is also the same thing, intensely enhancing mass in the body of the pancreas, which is seen as hyperintensity in the T2 weighted phase, or sorry, axial MR contrast image. Gastrinoma. This is apart from insulinoma, this is the second most functioning PNET. These are located in the anatomical region between pancreatic head and a common bile duct and within the first or second part of the duodenum, called as gastrinoma triangle. Excessive gastric production leads to the Zollinger-Ellison syndrome, either with a sporadic entity or a manifestation of the MEN1, MEN. 50% to 70% sporadic cases of Zollinger-Ellison syndrome are usually the result of tumors within the pancreas. The remaining cases are secondary to tumors located within the duodenum. Most of the carcinomas found in men1 are located in the duodenum. This is a axial. These both are axial CCD images taken in the venous phase, showing a mildly enhancing mass noted in the carcinoma triangle in the case of Zollinger-Ellison syndrome. Now, spleen. Spleen is a wedge-shaped organ lying mainly in the left upper quadrant, left hypochondrium, partly in the epigastrium, and is protected by the left 9th to 11th ribs. It is soft, highly vascular, and dark purple. It has two poles, that is upper, superior, and inferior poles, three borders, superior, inferior, and intermediate, and two surfaces, diaphragmatic and visceral. It is enclosed by a thin capsule that is easily ruptured. Diaphragmatic surface contains impressions from 9 to 11th ribs. The visceral surface has three impressions. These are gastric area for stomach, colic area for the splenic flexure of the colon, and renal area for the left kidney. Accessory spleen. It is a congenital anomaly caused by the failure of embryonic splenic buds to unite within the dorsal mesogastrium and extreme lobulation of the spleen with pinching of the splenic tissue. It is reported incidence ranges from 10 to 30% in the autopsy series. This is the axial CCT abdomen taken in the venous phase, showing a spleen, and there is a small round soft tissue density nodule noted adjacent to the spleen and is similar to the splenic ecotexture and enhancement. Pandering spleen. It is a rare condition in which spleen migrates from its usual position to the pelvis or lower abdomen of the pelvis. And how we will find that? Absence of spleen in the left upper quadrant, ovoid or comma-shaped abdominal mass, world sign, world appearance or of hyperdense or non-enhancing splenic vessels, and large spleen with minimal or no enhancement. This is a coronal reformat images showing showing a lobulated, elongated, and elongated mass noted in the mid abdomen, reaching up to the pelvis, having a enhancement similar to that of the spleen. So this is the wandering spleen. Splenic hemangioma. It is a non-encapsulated, non-neoplastic vascular channels of varying sizes, ranging from capillary to cavernous, containing a slow-flowing blood. These vessels are lined with a single layer of the endothelium. The vast majority are asymptomatic and are incidentally discovered. They may be associated with splenomegaly, abdominal pain, dyspnea, diarrhea, constipation. Splenic hemangioma. We can see this first image, which is a longitudinal ultrasound image showing the enlarged spleen with a hyperechoic lesion in the inferior pole of the spleen. And corresponding CT shows there is a discontinuous enhancement noted in the mass, which is seen in the ultrasound image. So there is a splenic hemangioma. Splenic hematoma. These are the solitary, multiple, round, well circumscribed, unencapsulated biology nodules compressing the adjacent normal splenic parenchyma. Focal fibrosis and cystic areas can be seen. Most splenic hematomas are hypoechoic solid masses but can be heterogeneous due to the hemorrhage or cystic changes. They are hypervascular on color Doppler ultrasound and post contrast administration. On CT, hematomas appear as isodense or hypodense solid masses, demonstrate heterogeneous contrast enhancement relative to adjacent normal parenchyma. Splenic hematoma. We can see the longitudinal ultrasound image showing a large, well-defined soft tissue density mass similar to that of the splenoid cortex with increased vascularity within. On CT taken in the venous phase, showing a peripheral enhancement of the mass. Noted. Splenic infarct. It is a result of a ischemia to the spleen and can occur due to the number of processes involving either arterial supply, the spleen itself, or venous drainage. The patients with a splenic infarction may present with left upper quadrant pain, some of Nan's constitutional symptoms such as fever and chills, while other may have a diffuse abdominal pain. Typical infarct is of a pyramidal wedge-shaped affected splenic tissue with apex pointing towards the hilum based on the splenic capsule. This is a longitudinal image of the spleen ultrasound showing a wedge-shaped area of hypoechoic area noted in the periphery of the spleen. Same is seen in the CCT, which is seen as a non-enhancing area. Splenic lymphoma. Which is very rare, accounting for the 2% of the lymphomas. The focal disease may manifest as a small circumscribed nodules, sometimes referred to miliary pattern, bulky splenic masses, and generally is hypoechogenic on ultrasound. The focal lesions are hypoenhancing compared to the background parenchyma, and they are best appreciated in a late venous phase, particularly when lesions are small. This is a longitudinal ultrasound image of the spleen showing a splenomegaly. On CCT image taken in the portovenous phase, showing a multiple non-enhancing areas noted within the spleen, noted with enlarged spleen. This is a Burkitt's lymphoma. And this is a counterpart image. Spleen is markedly enlarged with multiple non-enhancing areas within. B cell. This is a CCT image. CCT image showing well-defined non-enhancing area noted in the spleen. This is a B cell or lymphoma. Malignant B cell lymphoma in a 46-year-old man came for abdominal pain in the left upper quadrant. Longitudinal ultrasound showing a markedly enlarged spleen with non-enhancing area. Splenic rupture. Splenic trauma can occur after blunt penetrating trauma or secondary medical intervention. The spleen is most frequently injured internal organ of the blunt trauma. Patient may be present with upper left quadrant pain, left chest pain, left shoulder tip pain, and from diaphragmatic irritation and signs of hypotension and shock. This is a CCT image taken in the portal venous phase, showing a perisplenic collection with linear hypoenhancing area, likely laceration. Splenic metastasis, we can see here multiple hypervascular lesions noted in the spleen. Same as confirmed in the CCT abdomen axial bodies. These are the gamma Gandhi bodies, which are multiple tiny nodular miliary nodule type lesions, not scattered all around the spleen. They were described in patients with hemolytic anemia, lymphoma, and acquired hemochromatosis in patients received with multiple blood transfusions. Thank you.